So, well, hello everybody, and thank you so much for joining us for the CHA Special Interest Group Community Hospitals discussion. Delighted to see you all here. Do introduce yourselves in the chat box, and if you've got any questions, pop them in there and we'll keep an eye on it and make sure that we pick up questions towards the end. We're delighted to welcome Dawn Allen from Gloucestershire Healthcare Trust. They have 7 community hospitals, and there's plenty to say about their community hospitals. So we're delighted and can't wait to hear all about it. I won't ask everybody to introduce themselves because it will take a little while, but just the CHA committee members. So Richard, if you just say who you are. Richard Hallett is our treasurer, and we've got Kirsty Prothero, who is a director of the CHA. We've got Tom Brooks, who is our lead for Wales in the CHA. We've got Jan Marriott, hi Jan, who's been on the CHA forever and is a valued associate member. So we've got quite a few people from the CHA, and we have Eleanor, who is our administrator and organizer and solver of all problems, which is brilliant. So I think without further ado, shall we ask Dawn to start her presentation and tell us all about the Gloucestershire community hospitals, and then we can hear about, we can raise questions as we go. Thank you. I've enabled multiple share, so it should, well, yes.
Has that worked?
That works beautifully, thank you.
Hey.
You can see that, yes, lovely.
Excellent. Good evening, everyone. I'm Dawn Allen. I'm the Service Director for Community Hospitals and Urgent Care over here in Gloucestershire. And thank you ever so much for asking me to kind of come along today. It's evening, isn't it? But we wanted to talk about some of the work we're doing, and you'll see we've included the words here, aspiration and ambition. We are, as you say, we've got a number of community hospitals, and we're doing quite a lot of work to support their future and support their development and growth. So my first question really is, what are our community hospitals? Are they monuments to our past, or are they actually our beacons for our future? I'm hoping my slides have moved on and you can see my pictures. Yeah, perfect, fabulous. So one of the challenges here is that community hospitals are very well loved assets of our local communities, and that brings with it some huge benefits, and we work hugely and closely with our League of Friends, for example, but it also brings some real protectionist behaviours about how those sites are used, how they develop and how they grow. But actually for us, we work really collaboratively with our local communities, and I think, and we believe in Gloucestershire, that our community hospitals have a really solid base to go forward with, and it's something that we're developing, and indeed we've got some new hospitals currently being built. So we are moving forwards with our estate, as it were, but within that needs to come some development of who we are. So just to give you a little bit about us, as Helen said, we've got 7 hospitals. Some of them are a little more weathered than perhaps we would want them to be. Others are new, funky, beautiful, brilliant buildings, which have gone up over the last 10 years. And you can see a sample of those over on the side. Some of them are built in the heritage of our communities. Our coal miners over in the Forest of Dean are really affiliated to the 2 sites there. And we're in the process of building a new hospital there and supporting them to come with us on that journey, which isn't always easy, but also that benefit of modern healthcare facilities. How do we make sure that they can access those and those services that come within? We have minor injury units based within all of our hospitals. So we have urgent care services sitting alongside us, which is really important. We have X-ray facilities and endoscopy. We've got theatre units. We've got 2 of those. And we've got lots of outpatient appointments that happen. So let's just give you a little bit of context. If you don't know Gloucestershire, it's rather beautiful and probably does present pictures of forests, cows, sheep, and certain styles or ways of living you might see in Country Living magazine. But it does mean that our community hospitals are very disparate and spaced out. Gloucestershire is 1,200 square miles. So my team up in the top there where the moo cow is and the red triangle, that's North Cotswolds Hospital. And it's beautiful, but it's 20 plus miles from anywhere else. So we really do have sites that have to paddle their own canoes. There isn't a resilience workforce. There isn't often solutions or medics that can get there or paramedic crews that can attend at speed. So we really have got high autonomy, big decision-making units led by an MDT, nursing 24/7 and therapy within the daytime. We've also got 2 outpatient units that aren't in hospitals, as it were. That's our blue triangles. So they're over in Bolton on the Water and out in Fairford. And again, really valid community assets that the public use regularly. And a lot of our outpatient activity is Gloucestershire based, but not entirely. So we have partnerships with Oxford, Swindon, Wye Valley. We've got some South Bristol services that come in and utilise our services. So you can see that we're really well spread out, but what we don't have is community hospital beds within our 2 big towns and cities. We don't have in Gloucester, which is our big cathedral city, and we don't have in Cheltenham, which we'll say it's a city, but actually it's a town. And the impact of that means that patients who need a bed with us are patriated out to the peripheries. And that's not always the best experience for them or their families. And it does make discharge management quite tricky at times. But certainly we try and use, for example, our forest beds for people from Gloucester so that we can get more used to those discharge pathways and opportunities. So that's what we have. And this is what we get up to in those spaces. So we deliver urgent care. So minor injuries operates 8 a.m. till 8 p.m, 7 days a week. And per year, we see circa 75,000 people through our door. It's huge. And those are all people who, were we not able to support them in our hospitals, would be going into that Cheltenham or Gloucester setting to access our emergency departments. And we use the word minor injury and illness unit. The public are not the best at recognising minor. We are frequently resetting bones and putting shoulders back where they're supposed to be and managing acute chest pains with some dodgy looking ECGs and things. So whilst we brand them as minor injury and illness, actually their clinical function to those communities that they sit within is that's a hospital and that's where I go when things are feeling a bit rotten. They're not big units, so some of them will be running on 5 to 7 staff at any one time who are emergency practitioners. Our smaller units run with 2 emergency practitioners with healthcare support. So it doesn't take too many poorly patients for us to really feel the heat within those MIIUs. And that's where the sites work really collaboratively. They'll work with our wards if they need some extra resilience or some support. We'll often release a HCA if we need to help them get through a busy period and stay safe. So the co-location of our urgent care services is actually really important to us because we can work together as a team out in those communities. We are principally a rehab and recovery network offering those pathway 2 beds, and there's 196 of those currently within the Gloucestershire system. That will change when we build our new hospital in the Forest of Dean, which will open early in next year, and then we'll move to 173 beds, and that's what we are working with at the moment. We've got some admission avoidance beds. Now, I'm an old-fashioned old girl district nurse, and I remember the days when there was less bureaucracy, perhaps, where you could work with your local community teams and say, actually, I really need a bed-based step-up for my patient to stabilise or assess, and then I'll fish them back out again. I don't want you to have them long-term. Work with me and I'll have them back. And that's what our community assessment and treatment unit, our CATU, is doing. It's 10 beds specifically within Tewkesbury Hospital. And a third of our referrals are coming now from SWAST, our paramedic Treble 9 provider. And this is taking people straight to an ACP-led unit where we can assess, provide intervention and treatment, and our length of stay is between 7 to 10 days, compared to your standard pathway 2 patient who's currently with us for between 30 and 40 days. So we can see the benefits of those CATU step-up pathways. And this is one of our big opportunities as we go into virtual wards. Virtual wards will only work if there's a safe place to enable people to be stepped up to where they're not safe to stay home on their own. So our CATUs are a really solid asset into our Gloucestershire system now, and we're looking to expand that and move forward in the time ahead. We've also got 14 specialist stroke recovery beds within one of our hospitals, so that's down at the Vale. And we have our hyper acute stroke unit, our HASU, over in our acute trust, and also an acute stroke unit over there. And then they have a couple of choices. They can go for our enhanced supported discharge, our ESD, and get people home with that supported team. Or if people still need bed-based care, they can access these 14 longer-term rehab and recovery beds. And in there, we've got specialist dietitians, speech and language therapy. We've got some clinical psychologists and psychology assistants. We have consultant stroke specialist support and GP cover in there as well. And patient outcomes are really, really beautiful. So it's lovely to have that specialist offer within our community estate. The consultants come and see us. They do their outpatient clinics from within our sites, and we've got about 20,000 outpatient clinics a year across those 9 different places. And that's 20,000 people who can easily access care and assessment and diagnosis and treatment within their own affiliated community, and that really matters. We're doing more and more work with children, recognising that for parents and for families, it's sometimes quite stressful and difficult to go to those big centres where perhaps things feel a little bit more overwhelming for young people. So we're working a lot more with those. And post-pandemic, the world has changed. I think anyone will see that now telephone triage is bread and butter. Virtual assessments are much more common. So we have seen a reduction in our activity, but that is slowly recovering as we work with our system partners to take that forward. And those same consultants will come up onto our wards. So we have care of the elderly presence on our wards as well. Specialist Parkinson's disease consultants, for example, will come up and see those patients when they're down with us, which is really helpful. We're also part of the diagnostic pathway for Gloucestershire and looking at community diagnostic programs. We're about to build a big diagnostic hub in Gloucestershire. In fact, I think it's already up, but we offer things like X-ray and endoscopy. We do 50,000 X-ray sessions per year, and that's huge. And that will take, for example, the patients on MIIU. It will take the patients that have come through our beds that we have a deterioration. Perhaps we're looking for a degenerative condition. Maybe they've had a fall and we're looking for a fracture, or they take that primary care activity that people need to be X-rayed as part of routine work and procedures. Our endoscopy teams are really busy. We run 2 big endoscopy sites and we do 500 odd lists per year. One of our biggest growth markets, sadly, is bowel cancer screening, but that means that we can work with the 2-week waits and get people in and get them seen, which really does matter. In our theatres, we do all sorts of funky and dynamic stuff, and we do between 400 and 500 theatre lists per year. We particularly focus on a supportive environment for those young women going through terminations of pregnancy and support them to receive compassionate, kind care close to home. And actually, the lists that we put through our community theatres tend to be women who have additional supportive needs. So that really matters that we can do that in a kind way for them. But we do ENT, we do gynae, we do breast work, we do lots of eyes. My nemesis is eyes, so I wouldn't go into that list, but we do all sorts. We do some trauma orthopedic lists for some of the urgent work that needs relatively minor fixes. We're still doing general anaesthetics, and we work with our local acute trust to make sure we're safe and well governed. But again, patients our feedback from surgery and theatre use within all of our sites is incredibly positive. What is challenging is finding a workforce, looking for ODPs and nurses who want to go and work in theatres and come and work with us. That can be really challenging, but once they come, they tend to be incredibly happy in what we do because it's a really nice environment with big modern facilities that they can utilise. We run specialist dental clinics, and these are for those patients, not your bread and butter high street dental care. These are often people with a learning disability or people who have supported need for access. And we have all the kit and all the equipment, and we have obviously longer appointments and time with those specialist dental services to make sure people get what they need when they need it. And then we see ourselves very much as a bit of a beacon for our community assets. So we work with Age UK, Carers Gloucestershire, we have Citizens Advice in, we're working with Artlift currently, which I'll explain a bit more in a bit. Our local councils, we run carer cafes, for example. trying to connect the people who come to our sites, and they are busy sites from 8 a.m. in the morning until 6 p.m. at night. There are people buzzing around everywhere. So we have a captive audience and a lovely space that we can work with community partners to broaden that awareness of what's available around them to help support them in their communities. Trusted and appreciated. I think this is something I'm an incredibly proud service director. I have got the most amazing teams. And every month I see my patient feedback data, and it's just beautiful. And I hold my hands up. There are times that we don't get it right, and we get the concerns and complaints like everyone does. But the majority of the time we deliver phenomenal care and beautiful patient outcomes. And we're increasingly working with our personalisation agenda so that we're really doing proper individual personalised care. And you can see the FFT that we get. This is just a snapshot really, but it's all incredibly lovely. And our place audits are also really positive. Place audits are challenging at times. Sometimes people don't fully understand where we're trying to manage our care environment to be, but they are part of our understanding of what good and effective care environments look like. So we work with those teams and take on board everything that they say to us. So what are we up to at the minute? Well, the Community Assessment and Treatment Unit is our flagship service, if you like. It's been running for a year, and it's now just been funded to continue ad infinitum, which is just fabulous. It's a proof of concept, if you like, that we've been able to assure. It's a unit that accepts patients between sort of 8:30 in the morning till about 6 o'clock at night. And we have advanced clinical practitioners working in there during those times. What we're looking for here is those older, frail patients who perhaps have had a fall and have deconditioned and need some help to get back on their feet, but they don't need and probably would go backwards if they languished within an acute trust for too long. Those people who have a simple fracture, but because of existing frailty, that fractured wrist means they need a couple of days just to find their sea legs again and have some support to be equipped at home to go home. We take patients who've got electrolyte abnormalities. We will give IV antibiotics, IV fluids. We work with patients with exacerbation of a long-term condition, principally a lot of heart failure and COPD, and an awful lot of bolus offloading furosemide going on within there, making sure that people are recovering slowly. We've got specialist support coming in from things like heart failure. We've got ECG equipment. We've got the X-ray equipment within there. We've got ultrasound scanners so we can get a look at people and see what's going on. And as I say, the length of stay in here is between 7 to 10 days. And a third of the patients go out with nothing. They are pathway 0 patients who return home to their care environment within that time. Some of those patients do move into our pathway 2 beds and need a bit longer support. But even if they do end up becoming a core community hospital patient, their length of stay is still shorter, having gone through our CATU into our pathway 2 beds, than it would have been if they'd joined us having gone on a long journey through our front door at the emergency department, into an assessment unit, into a hospital ward, and then eventually back out to us for rehab and recovery. So we've got real high hopes for CATU. We've got enhanced therapy within there. And it's been really interesting working with therapists around how do you do rapid assessment on patients when what you're really looking for is to prevent deconditioning, rather than looking at that full ADL assessment of how do you live your life at home. It's about that here and now mobility and motivation. So that's been really interesting working with them to understand how you need to goal plan differently. We make sure that the rooms that we use are fully set up for independent patient mobility. They've got wardrobes. We practice the end PJ paralysis approach. It's very much up and about and let's get you going. Being unwell doesn't mean you need to sit in that there bed. We'll work with you and do what you can. And it's an approach that is really working for us and working for patients. We do have some GP time in here. We have about 4 hours a day of GP support into this unit, as well as another 10 beds, which are pathway 2. And it just comes together really well. The ambulance trust and primary care are really loving this access in for direct beds. We do take end of life patients in here under the premise normally of supporting a symptom palliation, whether they're in symptom crisis or really variable in their clinical profile. We'll bring them into the CATU and look to review their medications, work with their syringe pumps, for example, find a regime that works for them. And some of them then go home and receive their end of life care support back in their own home. Others stay with us and we support them till end of life, and that's absolutely fine by us. That's a lovely part of care. Moving on to our Enhanced Pathway 2 programme then. EP2 was a concept that we didn't dream up, but we thought we'd have a little go at. And I went out to my teams last summer and said, if we took the brakes off and I said to you, I need you to help me reduce the length of stay, but as long as we stay safe and legal, you can do what you want to do. They all looked at me like I'd lost the plot and said, we've got to do a QI project. And we said, well, no, because I don't want you to get stuck in the planning bit because we don't quite know what we need to do. I want you to have a go and I want you to be brave and I want you to chuck all those ideas at us. And by golly, did they pick this one up. So we took a ward of 16 beds, which at the time had a length of stay of around 35 days. We've been playing with this team, doing all sorts of things. We've bought a kettle and a microwave, simple, low-cost things. Most people nowadays do not go home and cook meat and 2 veg. What they do is they get a meal that they can get out the freezer and they heat up in their microwave and they want a cup of tea when they start their day. So we need to make sure that those core skills of living in the modern world they can do. And we didn't want to have to keep going up and down to the OT kitchen. It made sense to have something on the ward we could access much more dynamically. We've worked with, I mentioned Artlift earlier, and they're coming in to do programs of art. We've got communal tables now in the middle of the bays. We get people up to socialise and have breakfast, and they argue over the marmalade. And I just think that's beautiful because that means they're interacting with other people and not just sat by their bed waiting for the next meal or the next therapy intervention to come. So we work with Artlift and we're starting to look at how we can draw and express our emotions. And it's one of those things about that personalised care. We invite the patient carers to come on and join as well. So if a spouse is available, come in, join with us. And it helps often to unlock those emotions about perhaps worry or anxiety about going home, that fear of falling again. Things like that are starting to emerge through the Artlift programme. We've got bed and chair dancing. We've got maracas, tambourines, drums, and Alexa devices that play whatever music we'd like. And the therapy team support patients to do this. And it's just a really uplifting part of patients' day. And it's about punctuating the hours that people spend by their bed, giving them a reason to get up, get moving, get mobile. And it's really helping us within there. We're looking now at training all of our staff, and we have some funding from our ICB around motivational interviewing and health coaching in order to encourage that personalisation, what matters to you agenda, and the language that we use. I sit here as a district nurse and I'm well aware there are times when things I do are for the benefit of my time, but not always for the benefit of somebody's rehab potential. So we need to be more mindful of that and help colleagues to use the right language to support patients to feel empowered to do what they need to do. Within there, we've also introduced a new role, which is a health and reablement assistant, which we've put in at band 3. And we've put this on 7 days a week, 24 hours a day. So there's one on every single shift now on this ward. And that's about helping us all stay true to the rehab and recovery goals of patients. Because it is easier sometimes to put a pair of socks on yourself, but that doesn't help someone achieve that goal that they need in order to go home and live well. One of our biggest stumbling blocks to discharge, which I think every community hospital will face, is nighttime needs. But actually having these health and reablement assistants working across the night shift, we're able to then work with the therapy team to say, well, maybe they need this, maybe this would be a better solution. Actually, padding them up isn't going to help. We need to speak to the continence team. And it's only through having these health and reablement colleagues there and looking at aids and equipment that some of our patients have been able to go home without, overnight packages of care, which arguably means placement within a care home. So our EP2, when we did the evaluation work in January, showed that when you take away the number of the patients that were non-criteria to reside, which we're speeding up our pace within Gloucestershire, our home first offer now is really gaining traction. But back in January, February, we were having big delays from the point at which we said someone was ready to leave our care to them actually being able to go. But if you took those numbers out, the length of stay on this ward that we practiced on went from 35 days to 13. And that is a huge difference. So it's about those early conversations with families. We have family meetings now within 24 to 48 hours rather than at day 5 or day 7. Our therapists are doing co-created goals with patients and they sit by the beds and we can see what people are trying to work on. We talk to carers and families. We run carers cafes and we have coffee mornings for them, because we can't get away from the fact the majority of our patients have someone on the other side of the front door who is a carer, and without supporting them to do well, we risk both of them failing in the future. So a lot of what we're doing is about enabling people to go home with connections. We're currently working with a knitter natter group and some public patient transport setups so that people can start doing that when they're with us, make some friends, make some colleagues, recognize some faces, and then we'll set the transport up. So when they go home, they know that on Wednesday, they're going to be picked up and go and see some people they've already met. And it's that social engagement, it's reducing social isolation and all that challenge that comes with it. And EP2 is nowhere near finished. We're rolling out all the concepts that have cost us nothing to all of our sites, but we really are just starting to scratch the tip of the iceberg here in that personalisation and real ambitious care. The biggest learning for me when we talked about EP2 is we talked about asking our therapists to take positive risk. After 6 weeks, they honestly came to us and said, we're not quite sure what you mean by positive risk. Now, we'd made the assumption that if we gave them permission and said, the organisation will work with you, come on, let's go. Actually, they were still cautious because they didn't fully know what we meant. So we've done work with clinical psychologists with them to help them feel more comfortable with what we were asking them to do in terms of changes of practice. So EP2 is one of our flagship programs, and it leads us into some different conversations in our ICS about where do we go with our beds, what do we want our discharge to assess beds and care homes to look like in the future. Really, everyone should have that opportunity towards rehab and recovery through Pathway 2. So how do we create a better generation of flow so we can do that and support our system better? Plugged into that then is some further work around reducing our length of stay. This is a quality improvement programme with a number of threads sitting underneath it, all of which are helmed as pet projects by different ward managers or motivated colleagues on the wards. And some of this is simple. We've got some pool cars. Why are we waiting for transport for some of these patients when our therapy colleagues could take them home and actually get the bearings of home, see how they're doing, and if they need to, they can go back tomorrow and check on that person if that's the right outcome for them. So we've got a bit of a brave approach to how we get patients home, less reliant upon our patient transport services, much more encouragement of families to help us get patients home. We do seem to be heavy towards our use of patient transport, and we don't always need that. So again, it's about that dehospitalizing the patient, going back to normality. You'd go in a car to have Sunday lunch or to go to your families for Christmas. So let's get you home that way. That would be more pragmatic of us. We've been doing lots of work around TTOs and drug charts and making sure we get everything ready to go. That's a really tricky one because if you go too soon, you end up with a change of prescription and a bucket full of meds that have been dispensed out. So work around that is coming and improving. We've got an onward care lead who is helping us with understanding of the discharge pathways. I think like many systems, it's quite complicated. There are so many services now there to help, but navigating your way through can be very tricky. So her role is to work with our discharge coordinators as part of the QI programme to help them understand the toolkit, to connect them into our patient flow team across our system so that we can bring that length of stay down through that pragmatic approach to working. We've got posters up across all of our beds now that say, why not home, why not today? It's connected to all the NHS England work, which was all guns blazing pre-COVID and then got a little bit stuck, as most of the world did. But we've reinvigorated it. And that's the question we're encouraging patients to ask of us. It's actually come quite challenging to some carers and relatives when we say we're looking to plan for home. And they say, but he's only been here 2 days. Yep, but that's what we're playing. That's what we're doing. It's not... We have to work to dispel the myth that hospital is a safe place to be, because for many people it's not. We see our VTE harms, we see our falls, we see our pressure ulcers, we see our IP&C challenges. So encouraging the public and relatives to understand that home is generally the best place, but we'll set things up around you to support you. But we are going to have those conversations as uncomfortable as they are. And that's about building confidence within our team through the QI process and programme. We're doing the What Matters to Me. We talked about what we were going to call this, but Gloucestershire has a really well-established programme. It's an orange folder. And in there are things like respect documents, but also the What Matters to Me, that personalised care planning, thinking about anticipatory need as well as here and now needs, looking at who collaborates and supports you at home. And we've brought the construction of those orange folders now into our wards, and we're just at an early stage of getting this moved forwards, so that when people leave our care, they will go to the care of other providers, and they'll understand the journey that person's had, what their goals, wishes, ambitions are, and what we're working towards, so that we can start to have that real shared space across where patients are discharged to. And it's a really powerful question, isn't it? What matters to me? And that's so different for everybody. And I think as professionals, we were very guilty of prejudging that and assuming that what mattered to Mrs. Smith was the same as perhaps what would matter to Mr. Jones. And some patients have some really beautiful and heart-wrenching reasons to want to leave hospital or not. Some people love the company. What matters to me is I've got someone to talk to each day. So how do we help work with them to make sure that when they go home, they've got some setup around them that helps them? We're currently looking at an inpatient therapy review, and we are starting to think about 7-day working. It's quite tricky. We have a bit of an old-fashioned therapy model, and I haven't got enough of them. So what we've said at the moment is, through last winter, we asked our colleagues if they wanted to work weekends or bank holidays as extra shifts as bank, then that was great. We'd be really grateful because it was winter, and we recognise that when patients are admitted on a Friday afternoon, they probably don't get a therapy assessment until the following Monday. And in that time, that risk appetite of your nursing team diminishes, because you don't know how brave you can be to mobilise somebody, or whether the frame they came in with is the right thing they should be having. So it was really important to us to get therapy assessments as fast into that pathway as we could. And our staff were amazing this winter. We've had really good coverage, apart from a few weekends between the beginning of November to the end of March. We covered every weekend for between 2 and 4 hours. It wasn't huge, and it was done, and actually for colleagues, they really quite liked it. So we got to a point where we said, well, we can't yet enforce this. We're not about to say you've all got to work 7 days, but if it suits you, we're happy for you to do a blended approach. And that's what a lot of our staff are doing. It works with childcare, it works with caring responsibilities. Some people really like having a day off in the week, so they're happy to work 1 weekend in 4. So part of our therapy review is we've got a number of physios, we've got a number of OTs, we've got 1 dietitian, which doesn't feel a lot for 196 beds. We've got speech and language therapy focused within our stroke beds, but not that accessible everywhere else. We've got a podiatry offer, but it's about a referral approach in order to get it. So our therapy review is thinking about what do we need for the future? And if we increase that therapy provision, can we do a better, proper rehab and rehabilitation offer into our beds? And that dovetails into that conversation about what the future of beds in Gloucestershire needs to be. And then, because I'm old and I've gone round the circle many, many times, we've got Golden 6 clinical improvement projects. And this is about those core things that good patient care require. We need to think about nutrition and hydration. We need to think about pain management. We need to think about continence. We need to think about clinical obs and news and deteriorating patients and falls risks and pressure ulcers and all those things that they're not sexy. They're often found when you're giving someone a bed bath or just talking to them, but being that kind, compassionate clinical professional that we are. And yeah, we can build all the sexy stuff on top. We've got some amazing advanced clinical practice going on in our sites, but without those fundamentals of care, we really are never going to succeed. So we've got a continual programme looking at our Golden 6 to enhance the way we deliver end-of-life care or manage patients with delirium, for example. So that's something that we just keep going around the loop. And I'm incredibly lucky. I've got training and development facilitators 2 days a week working on every single ward, which means that alongside those other experienced colleagues, they can take learners in practice, or I've got international educated nurses now on my wards, and they can really help them bed in and solidify that exemplar practice that we expect for our patients. So how do we work with our system? Well, it's really hard, isn't it? Because we do find ourselves being pulled towards the acute trust and facing them to try and help move patients back out and get them repatriated closer to communities for their onward rehab journey. But increasingly, we're strengthening our ties with our primary care networks in order to support that step-up offer for primary care to be able to contact our single point of access, and we can look at direct admission, avoiding all that pathway through that just doesn't always feel necessary. So that's part of our big, strong future, working with our PCNs as we go forward. We have a number of GP service level agreements in place for our medical cover, and we take trainee GPs. Whether our future is in the SLA market, we're not quite sure. Primary care is, as all sectors of the healthcare service, really in a bit of a state of change. But our GPs are beautifully affiliated and very patriotic of the hospitals they work with. And it's those relationships that really matter. There's an awful lot of goodwill goes in to delivering great care for our patients. We've talked about, we have the frailty consultants coming. We're developing our ACPs. I've currently got 4 ACPs working across my sites, and we're looking at expanding that as we go forward. This means I can open up career opportunities for colleagues, but it also means that I have better coverage than that SLA, GP SLA can provide for me. So instead of 4 hours a day of medical cover, I might have 2 hours, but I'll have 8 hours of ACP. So we're very much looking at benchmarking and learning from our neighbouring trusts who've gone down this pathway and done this. So we're really excited, but developing those ACPs is not a quick fix, and it's quite a long journey. So work is happening within there. Our beds are always in demand. We have a waiting list, and some days it's quite low, but consistently it sits around the early teens. There's always a customer ready to come to our beds. And our bed occupancy is about 98%. And I don't think we're alone within that, but we maintain really good quality of care despite that pressure. And it is a pressure. Those beds really are hot. They're just moving and turning. The impact of that means that we have to think about our overhead for our workforce. How do we give them that time for their training and development and growth, supervision, PDRs, for example, if we're just constantly moving patients after patients after patients. So there is a challenge within that, but that's okay. We're working with our teams to make sure we can do that. We've talked about us working as a step up. We have something called a homeward assessment team based within the front door of our emergency departments, and they are increasingly growing their relationships to the community hospitals to catch those people who've made it into the emergency department and divert them back. They do need bed-based care, but they don't need to be in an acute trust, and their outcomes will be improved if they come straight to us. So more and more step up facility is coming. We've talked about end-of-life care. I can guarantee with my hand on my heart, my teams will move hell and high water when they get those calls that say, I've got a patient that really needs to be in a bed and we're struggling to get the control of their end-of-life symptoms, or the social situation just isn't tenable any further. The teams do an amazing job with end-of-life care. We've just set up, for example, some pre-bereavement and post-bereavement locality support up in the North Cotswolds. And that came from a relative who was with us. We were looking after her husband who was dying with us, and she really wanted to access the pre-bereavement offer, but it was in Cheltenham, and she said, I don't want to leave him, so I need something that's closer. It's too far for me to go. So she's worked with us to set that up, and that's now going live and enables people living in the North Cotswolds, which is a very beautiful but very rural area, to access that pre and post bereavement support much closer to home, so they can still remain connected to their loved ones. So a really nice positive move in there. We've got social workers embedded in with us. We really love our social workers. They are an absolute linchpin to helping us get people home. And there's a real sense of their place within our MDT, and you feel it if they're not there for a little while. So we enjoy those co-relationships and co-locations. And then we have mental health nurses. We've got some staff who are part of my core bread and butter workforce who are RMNs rather than RGNs, but we also have mental health liaison who work with us, usually most days a week. There's somebody within the teams. But we've done more work around things like Pinch Me for delirium and making sure that we're managing those patients much better. We've improved our enhanced supervision approach in terms of when does one-to-one make things more easy, or actually sometimes it can be a bit inflammatory. So do we need to put enhanced workforce on the ward, but not necessarily on a one-to-one basis? It just depends. So those mental health colleagues help make sure that we've got really solid plans so we know what to do should a patient's mental health symptoms escalate. And a great place to work. I'm really proud, as I've already said, of the teams I lead. I have a phenomenal matrons network, ward managers that you'd probably all give me a lot of money to have, and you can't have them. And the beauty of that means that we're strengthening our therapy relationships and therefore building career options. Apprenticeships are a wonderful thing, but you've got to have some brave leadership to let people go. And we're getting better at that. 1 day a week out, so you can go and develop yourself to be a registered physio, for example, or a registered nurse, or do your ILM in coaching, mentoring and leading others, that matters. So we're working with our therapist in particular to do that. And we've put 2 professional leads in now. I've got one for OT and one for physio, and they work across all of my AHP workforce to improve that practice behaviour. We get lots of students. We have student paramedics, we have medical students, student nurses, obviously by the bucketful, student therapists, and we've started to take T-level students. So when I was a wee lass, I worked in a care home when I was young, and it's the thing that made me realise that working with people was just the place I wanted to be. But for the younger generation, accessing those placements for work can be quite tricky and actually can be really scary. So we've taken on T-level students who are age 16, 17, and they work with us for 2 years. They come on, we're called their industry placement. They come to us 1 day a week, and that's an unpaid placement that they come and they're part of the workforce. And they sit alongside us. They receive the same induction approach, so they get their manual handling, IP&C, for example. But then after about 4 months, when they've done a number of days, we offer them bank contracts if they want them. And then they're able to work as HCAs with us. And actually now we incentivize all our shifts for bank working. It's a really lucrative offer for these people to come and work alongside studying. And we're only just into year 2 of this, but many of them have now got their places lined out for going through nursing and things. So we're really proud of what this brings. That succession planning and future generation stuff really matters to us. We're nurturing our internationally educated nurses. I've got about 40 of them. They're just awesome, but it does take them a while to find their way. You saw the map of Gloucestershire. We're spread out around it. It's quite a culture shock landing in the middle of Cirencester and then realizing that you're not going into a big acute hospital. So we've had to do a lot of work with our internationally educated nurses about the role we want them to come and do. But they're developing beautifully, and I have a specific training and development facilitator just for all my international nurses, and she really supports them, because culturally, things like having a conversation around leading into end-of-life care can feel really difficult for some of these colleagues. It's not what they've practiced before. So we're really working with them about understanding how we can work with all of our patients and how we can grow their skills. We've also had to teach them not to say yes doctor, no doctor, because doctors are not always king, and my clinical director might shoot me for that. But part of good, solid, safe practice is all professionals feeling able to say, I'm not sure that's right. Have you looked at, or could we do an assessment of, or do you think we could discuss? So encouraging them to be an equal partner in patient decision-making and pathways, and fundamentally the advocate for that patient. So that's been quite a culture change for a lot of our teams in supporting those nurses to think differently and perhaps be a little bit less done to. There are some significant cultural differences we need from them. We've got lots of staff on the apprenticeship, and we're very ambitious about where that leads us to. I've got my hands on, we've got some big display boards about career ladders. What can you do to get you from a trainee, a T-level person, into a band 2 healthcare assistant role, into a band 3 trainee nurse associate, into a registered nursing associate, to a staff nurse. And we've described all the way right up to my job and beyond of how people can have careers with us. But because we're not entirely selfish, we've also put within there enrichment opportunities, because I genuinely believe the best leaders of the future can't just stay in one place to gather their experience. So we talk about them working within other community services, working within mental health, working with our urgent care teams, for example, working in primary care to go and collect more experience. And we'd love to have them back, but actually going outside of your comfort zone is a really good space for learning. So we're encouraging them to think more broadly, and as an integrated physical, mental health and learning disabilities trust, we've got some amazing opportunities to offer. We talked about the professional development escalator and the ACP pathway. We're really immature in this, but we're coming and we're really determined to make it happen. We're about to go out for some staff at band 7 who are in their last year of training towards ACP to bring them in and develop them into 8A roles. We're running a matrons development program, which is about helping them to find their voice as senior leaders. One of the impacts we observed post-COVID is a lot of shutdown behaviours and thinking, because so much was dictated to us through the pandemic, through nobody's fault. It was just that's the way we all stayed safe. So with the matrons now, we're encouraging them to work more as a network, to have a visible presence in those key meetings where the voice of our hospitals needs to be heard, and to do some of that external representation work as well, and be real beacons. I go back to, what are we? We are beacons for ambition and aspiration, and my matrons need to front that, and they're starting to learn how we can do that more productively. So some OD help going in there. We halved our HCA vacancies in the last 6 months. HCAs are a tricky breed to keep and grow, but we've done a phenomenal job in supporting them to come to us through things like reviewing our induction, helping some of those T-level students come on board. We've had some people who've come in as apprentices and then gone into our healthcare assistant roles. So some really positive work within there. We've been working with our local inclusion partnership trust and the Prince's Trust, and we've developed something called a ward assistant role. And what this is about is, sometimes it's not nursing, it's not catering, it's not portering, it just is something that needs to be done that doesn't require senior level skills, it just needs people skills. So we've recruited 4 people to test and learn. 3 of them have been recruited through inclusive processes. So we have somebody who has is on the autistic spectrum, but high functioning and very capable and able. We have somebody who has hearing impairment, and we have someone who has a physical disability. And they're there to help us prepare bed spaces, make sure everyone's had a drink, make sure the water jugs are topped up. They'll play puzzles with patients. So when you get someone who's starting to look distressed and might just need some space to be distracted with something fun, they'll do puzzles. We've got crosswords and art books and things. They make sure the telly's on a program someone wants to watch. They'll sit and talk to people and relatives. They take them out in the garden. They'll wander around with them if that's what somebody wants to do, if they want to mobilize with purpose, because that helps. They'll go with them and have a chat. Equally, they'll make sure that we prepare the bed spaces, we change the curtains, they'll answer the phone, they'll answer the doors. And this means that it's a little bit like Tesco, I'm here to help. And I wanted I'm here to help on the back of their polo shirts, but we couldn't work out how to embroider it. Isn't that rubbish? But we're really starting to feel what these guys can do for us. And again, this is a test and learn, but these are colleagues who would not have come to my door looking for a job working in the NHS had we not positively recruited them through those inclusion pathways. And particularly the Prince's Trust, we've recruited 2 colleagues through that route. One went straight into a HCA, one's gone into ward assistant. They're people whose life chances have been affected by the decisions they made through their early years into adulthood. And they didn't have the same opportunities as you and me. And it's just really lovely to be able to open those doors for people. And they are just fabulous. So we're getting braver in how we're thinking about new roles and things. We've talked about the health and reablement roles and how we're trying to expand that forward now. And that gives a career development opportunity for colleagues who don't want to be full rehab assistants, like doing the care work, but actually we need to mash the 2 together a little bit better. And then we've got some rotational opportunities. I'm very lucky that I've got an urgent care portfolio and a bed-based community hospital portfolio, and the 2 go beautifully together. I can put people into minor injuries. I can put them at the front door of our emergency departments in my admission avoidance teams. They can spend time on my ward. So we're just developing together what is our rotation package needing to look like in order that people might join us as a newly registered nurse, go on an accelerated, supported rotational program, and then we'll guarantee them a band 6 senior role at the end of 18 months, 2 years, once they've got that mileage and grown in their competency. So where are we going? What are we up to moving forwards? So we need to do more collaboration. Sometimes we get things, I guess, like everywhere, where there's a brilliant thing happens over in that hospital, but nobody tells anyone in another hospital. So we need to be much more collaborative and make sure that improvement that happens in one space is cross-pollinated and shared, and everyone else gets on board and goes for it, because some of it's just real no-brainer stuff. And that comes back to how we structure. So we separated our governance meeting, and we now have a clinical governance meeting and then a separate service development, innovation and improvement meeting. Because what happened is that fun, fizzy stuff of the improvement you're trying to do kept getting drawn down into the what's gone wrong and the governance stuff. By giving it its own space, we've been able to really protect and accelerate the pace of change. We're looking at that culture shift, that pacey admission and discharge, revising our assessments towards positive risk-based practice, bringing in things like making every contact count. That's a big culture change for some of our colleagues, and some of them are coming at a faster pace than others, but that's okay. We'll get there in their time. Nobody's being pushed, but we do need to move towards a much more modern pace of delivery. Looking at breaking down those barriers, that co-created with patient improvement, goals that start with us, but talk about what goals the person wants for 5 months' time. That's okay, because we'll start that journey, and then that same goal plan will follow the patient home for community therapy to pick up and follow on. So you reduce that duplication, and people tell their patient story once. It's that big thing, isn't it? Don't waste people's time, and we're trying to be much braver in that to help people go home with a plan that just goes with them. We've talked about the outreach bit. If it makes sense to get someone home that someone they know goes in tomorrow, that's fine by me. Why would we not do that if that would mean that we risk the failure of discharge? So we're doing some of that work. I've talked about permission quite a lot within here, and I think that's one of the biggest bits that my teams have been feeling from me, is that permission to try. Give it a go, come and tell me if it goes wrong, absolutely, but if we don't try, we'll never know. So they're really starting to learn around permissive leadership and what that can do, and that creativity that comes with it. We've got a revised approach to learning, so we're doing the PSURF, as everybody will be, from September, but we're doing swarms now already, so when things don't quite go to plan, our moderate harms and above, our patient safety team will go and create a swarm on the ward, usually within about 72 hours. And the teams are finding those really supportive conversations, exploring what worked well, what could do better. Is it part of themes that we already know, or is this something new that we might need to think about in a slightly different way? But it's that supporting of learning and surfacing those things that we can do differently from day one, or those things that need longer term investment and processing through. And then that cross-pollination. So when we know something went wrong in one hospital, we're really quick to assure ourselves that that couldn't happen in another, because we're working to that revised learning framework. It's a little bit like the aerospace industry. Whilst they might compete for your business when you want to go on holiday, when something goes wrong in the aviation industry, they all share the details of the incident, because none of them can afford to have a safety record that isn't tip top. So what we're doing here is saying when something happens there, we will share that as quickly as possible to all sites. An example this week is we had a patient fall and they grabbed a door as they went down, and the door came off its hinge. And it was to do with one of the pins. We've gone around every single hospital since, and we found another 3 pins that need replacing. But instead of just treating that as one incident in one hospital, we very quickly recognized we needed to check some other sites as well. So some of that stuff wouldn't have happened before because we weren't sharing in the same way. And then strengthening our learning and improvement, capturing our quality improvement progress. I've now got a business and projects manager, a role we never had before. And with her support and arguably her much more organized thinking than mine, we're now able to be really demonstrable in our progress. So when CQC pop in and say, tell me how I know that you've embedded the learning, I can track that back through improvement programs and action plans, things that have been quite difficult for us in the past. We're busy, all of us run at a rapid pace. So those things are important and are coming in. And then our audit outcomes and actions. Audit is owned by the teams. I don't want it to be seen as an outsourced activity. So we have champions for all of our audit, and they have that space and time each month to come together with their peers. All of my ward managers, all of my theatre leads, all of my outpatient leads come together, and we can all learn together about the audits and the changes that we need to do. And that's seeing a pace of change that we've not had in the past. So do we have a bright future? Well, I blooming hope so. What you can see there is a picture of what our Forest of Dean Community Hospital is going to look like. It's a bit of a shell at the moment. It has got some walls, but for me, I've put the picture there because I think it's important that that's a modern healthcare facility, and we're delivering modern healthcare services from it, and we're delivering that in our community hospitals now. So whilst there might still be a feeling within our public population of respite beds, convalescence beds, a place where people go to recover from being in hospital, actually that's not what we are. We are busy, dynamic hubs operating often at the very nth of autonomous practice. And I'm really proud of that. And it means that we can give that diagnostic work. We can make sure that people meet their 2-week wait. And that really matters. If you're a patient who thinks you may have a cancer diagnosis, those 2 weeks will feel like an eternity. So we play our part by putting those facilities out there in communities. And I think for us, the leadership bit really matters. So you can see, you might recognise Andrew Wheeler in the photo over there, but the person he's with is someone from our single point of clinical access. And Julie helped us to set up all of our CATU activity. So instead of just working in our little box of community hospitals, we're reaching out and doing much more network-based collaborative stuff. And that's only going to be a positive outcome for us, we believe. And then in terms, you can see paperwork on the table. We've got a very ambitious digital future. I don't believe in 10 years' time, we'll still have a bucket full of paper at the end of the bed. We are a System 1 trust. We have lots of WOWs, workstations on wheels. I'm not allowed to call them cows, computers on wheels, so they're workstations on wheels. But the reality is there's not one for every bed. So we're starting to look at some technology that could be at the foot of the bed where our news scores go in, our must goes in, our weights, our heights, our pressure area checks, all the stuff that currently food charts gets done at the end of the bed. We could digitally do that and it could feed into our patient record system. Speaking to some other trusts, the limiter in that is Wi-Fi reliability. And one of the trusts we spoke to had multiple providers of Wi-Fi to the same sites in order to be sure that if A went down, B and C were always going to be available as backup. So the digital agenda is moving much further forward for us. We use a lot of FaceTime. The ward assistants do quite a lot of that. Everybody today seems to have WhatsApp, I think it is, video thing. So we've got a device with all of those on so they can talk to family and relatives. And that kind of technology isn't always accessible to some of the patients we have who are perhaps a little older or a little less digital savvy. I don't use a broad brush there. Some of them are just awesome at what they can do, but others need some help. So we've got the iPads that means that we can do that and they can connect in with family. So I think we do, hopefully, fingers crossed, have a really bright future in terms of the care we deliver, the services we provide, and the buildings from which we start to deliver that practice. So I will throw the floor open to any questions.
Oh my word, thank you so much, Dawn. You've given us a fabulous insight into the workings of your trust, the way that you've got person-centered care, the respect for people who use your service, the nurturing of staff. I mean, there are so many lovely warm messages coming out and a lot of excitement about your innovations and your service developments. I would imagine people are very, very keen to work in your trust because it's inspirational. Doesn't even begin to do that justice. But you've covered so much. Thank you. Can I open up to questions? Does anybody have anything that they particularly? I wouldn't know where to start.
Is it okay for me to say something? So my name is Deepa. I'm one of the HP clinical leads in Southampton who work across two different areas and sites. So currently we're going through a massive transformation within our service as well. So we are Solent, we're a single trust, but what we're doing is we are like there's a massive sort of fusion project that's been that's going to come across in the next year. So we're going to be fusing with Hampshire and Isle of Wight, Sussex, and also Southern Health, which is a mental health trust. And on the sides of it, we also have got funding approved for a clinical unit of rehabilitation excellence at the Western site, which is being funded, and the works have started. So looking at all your innovations, and there's so many ideas for me to take forward on from there, and I'm really looking forward to receiving your presentation. Because the way you spoke about your sort of looking at and enhancing, thinking very differently, your knit and natter groups, you've got your sort of your dancing and bed and chair dancing groups, and also specifically about your innovative sort of your healthcare assistant / rehab assistant who are going to be working across over a 7-day, covering your nighttime as well, looking at the care for your patients. So then you can establish what is really their night needs. The one thing is, are they included in your nursing numbers? Because we've trialed something like that and they were included in the nursing numbers, which was so difficult for us to actually pull them out.
They are included in the nursing numbers, but but the rehab assistants remain on top of, they're not counted. So they are there as HCA hours. Yeah, but they're not, we haven't touched the therapy provision at all. So we funded it. It's cost me 60,000 for a year. We funded it as a top up. So they are in the numbers, but nobody else has been disadvantaged, because I think, as you say, that really matters that we do that.
Yeah, I really liked your idea about the audit champions. The only thing is where you've got more access to the direct acute setting as well as the community. We don't have that, unfortunately, because we are a community trust. We've just got, our community beds. So we're going to be having level 3 beds, level 2, and a neuropsychiatry specialist within the same ward with our community neurospecialist services and the community, independent services and urgent response and D2A. So we've got some innovative works as well. So we've kind of done sort of bed, patient pathways we've created with the acute trust, looking at where the gaps are and actually enhancing level 3. So we're not really level 3 anymore. We are general rehab, and there is a massive, massive piece of, work isn't there with even general rehab, which people are not really thinking about. It's not just elderly rehab. We are general rehab. We take adults from the ages of 18, so working closely. So, I mean, I don't know. Do you mind if I kind of set up like a meeting with yourself, if you've got availability to think about ideas, talk separately to the forum, because I'm very excited with everything you've established and want to learn from you?
You really can, because actually we owe you one in Solent, because we have your former chief ops with us now. So I've linked into Solent to talk about how you'd brought down your focused rehab stuff. So by all means, grab my email and it'd be lovely to talk to you.
Thank you very much, Dawn. Thanks, everyone.
Sorry, this is exactly what this is about, making these connections. If you don't mind, Laura Sacchatti is from Italy, and she's looking at the design of community hospitals for Italy, because as they're investing in 400 community hospitals, and I know she wanted to talk to somebody who was involved in a new build. So can I just connect you?
Of course you can. Yes.
Thank you so much. Yeah.
Hi, Laura.
And Laura, she's written a book on the subject, and we're putting it on the website. And anyway, so consider yourselves connected.
Thank you. There's lots of pitfalls, Laura. My colleague Lisa's on here with me, and I'm sure Lisa will testify. Things that we thought might work 5-10 years ago, now you sit here and think, oh, maybe not. One of which is climate change. I guess Italy's a bit warmer than here most of the time, but we've got air handling systems in our new hospitals. Actually, they struggle a little bit when we've got 30-something odd temperatures, which is actually becoming, I suppose, the norm. So even simple stuff like that is really important. And yeah, but be delighted to talk to you about some of the stuff that we're connecting in with and how we do that. And you've got Lisa on here, who's my queen of things like endoscopy, JAG accreditation and stuff. So we've got some really good knowledge base that I can plug you into.
Thank you. Thank you very much.
And we were talking about the function of community hospitals, how things change, flexibility, changing orientation, which we certainly saw during COVID. So, building that into the design is critical, isn't it? Any other questions? Anybody else would like to? Jan, you can't be quiet.
Jan's never quiet.
No, I just think, in some ways, I know you're saying that things change. I actually think in some ways we're going full circle back to the strong primary care connections, admission prevention, people not having to go through the awful loop of the acute hospital, but being able to come directly to their own local community hospital. So in some ways, I think we're going back to some of the best things, but with a modern framework and all the things that Dawn's talked about. But actually, it does feel like the community we're going back to being a resource that belongs and it owns, and the community value, because it's set in the heart of that community that we're serving. So I'm absolutely thrilled, because I think we've had 15, 20 years where we've been the community hospitals in a lot of places have just been somewhere where acute hospitals send people to as soon as they can, so that they can free up their beds without any real thought about what they're doing. And so I'm just really thrilled to bits to be getting towards the end of my career, and some of the best things about community hospitals are coming back again. But that's not uniform across this country by any means, is it? I mean, I look at Devon and the mess they're in, and the efforts we made to fight to keep those community hospital beds open, didn't we, Helen? And
yeah,
they pretty much all went, and they're in a right old mess in Devon. So it is not across the board. but I hope it would be really good, you know, to be able to, we've had bits of research, haven't we, Helen, and we've been involved in bits of research, but often it's been trying to demonstrate the effectiveness of community hospitals. And it would be really good, Dawn, if we could get a big piece of research. Now we've got a research and development.
We do.
That we didn't really have before, and a connection with academia to try and, because I think Gloucestershire is trailblazing. I don't know what, I mean, Kirsty, you've got experience in Worcestershire next door, and there's some things that are going on really well there. But I think Gloucestershire's doing an absolutely brilliant job, and it would be really good to be able to share that practice with some evidence base behind it.
I think the beauty for us is bringing back that CATU-based presentation, because in the traditional system, that would be very easy to cite within an acute hospital and call it an MAU or something similar. Actually, it took some brave systems decisions to say, no, let us do this. This is what we do. And the fruits of that are huge. And I think, you know, as Jan said, I go back to, that's what we used to do. It is, yes, there's ACPs at the helm of it. They've got far more diagnostic intervention, and the drugs they use are costing me a fortune, but rightly so. But that expertise now exists outside of acute trusts. And I think for us, this has always been about not blazing a trail, but because that sort of isn't my style, but it's developing and proving the concept just quietly in the background, proving we can do it, and then taking that evidence and saying, you know what, we actually can. And it's that bravery. And as Jan is aware, we're starting to get into some system conversations now that will define our future for 10, 20 and so on years ahead. And I think community hospitals in Gloucestershire now are in a much better place to see our future within there. Had we not done a significant amount of transformation work and developed our offer, I think we may have struggled to talk about what we are in 2035. But by golly, it feels like we've now got a real currency our system needs.
Yes, absolutely. I mean, I think one of the things that impresses me so much is your sense of purpose. I mean, I think there have been times when community hospitals have felt a little bit on the back foot and a bit sort of responsive to what the acute sector needs or whatever, whereas you're setting out a really strong framework that places your patients and your communities right at the centre. And I just love that sense of purpose, because I think you've communicated it so extremely well to us. It must be communicated that well to staff, so they know where they are, they know what they're doing, and that's exciting, and everyone is valued. I think it's such a strong message that you know what you're doing, and you know everything you're doing is for the benefit of your patients and community and your staff.
Thank you.
Kirsty, did you want to pick up on anything in relation to what we've heard, and also Worcestershire? Kirsty's a GP. She's also a CHA director.
I mean, what Jan was saying, so in Worcestershire, the community hospitals are going towards ACPs, covering wards much more, and having sort of salaried GPs. I just cover the community hospitals weekend now, so I don't think they've got that CATU type model in the community hospitals, which I think is a brilliant idea. It's almost a little bit like Jan said, how it used to be, where GPs could make direct admissions to the community hospitals, which, like you said, stops the patients deconditioning and going around the acute hospital, going around several wards and then ending up in a worse condition than they started off in. So that is, I can absolutely see how that worked. They tried something like that in one of the acute hospitals in Worcestershire, in Redditch, but then they closed it. And actually, thinking about it, it probably would have been better if they tried putting a frailty unit and staffing it properly in a community hospital, and it might have worked a lot better that way, directing the ambulances that way. So, but no, it sounds. It all sounds really, really interesting, and I like. And the other thing I like the idea about is, I think you said, when you've to help the discharges, getting somebody the patient knows from the community hospital to go and see them the next day when they've been discharged. Is that right? To just prevent a failed discharge?
Yeah, it's in pockets, but it's starting to come.
Yeah, so
it's
I
those
think
ones
that's
that you kind of think, do we need a follow-in? Do I need, because so many people thrive in their own environment, don't they? And we kind of look at it in a bed-based environment, it's easy to make a risk-averse decision, but actually when they go home, they generally do all right.
That's what we found in the stroke unit at Evesham Community Hospital, where there's sometimes quite a bit of reluctance to discharge patients. They've maybe had a significant brain insult from their stroke and cognitively impaired, but they could end up languishing on the ward for weeks, and we send them home and absolutely fine when they get home. And having that little safety net where someone who knows them is just going to go and check on them, I think that's a really good idea. I think it's a good idea for the acute to do something like that too.
And we are working with Worcestershire, so thank you, Kirsty, because actually they want to know what we're up to with CATU, and we want to know how they've done their ACPs in community hospitals. So I'm working quite closely with my opposite up in Worcestershire with Jan to share our love, because we need each other's.
What I would say about the medical cover, that's something that needs to be thought about quite carefully, I think, because not when I say medical, sorry, I mean the doctor, I'm not being rude, I'm saying the doctor cover that supports the ACPs, because with we went from Worcestershire and having SLAs with the GP practices to having salaried doctors, and it's I just think that needs to be thought through quite carefully. I think it's really good having salaried GPs within a trust, because I just think there's more integration with the teams within the hospital. But okay, that's great that you're talking to Jan. Kirsty.
I can't get over what you were saying about therapists taking patients home. I mean,
it came out of a why not. So somebody said to me, why can't we take them home? I know.
We used to do that.
I didn't know.
Evesham used to, the OTs used to go home before with them to see how they got on at home, and then actually go out with them on the day they were discharged. A lot of the things are not new, but we lost them for various reasons along the way. So I think it's a great idea.
We do have to have staff approved to do it from working well, obviously, to make sure they're not likely to have a seizure behind the wheel with a patient next to them, but and obviously they go out in twos. But we've done a few of them now, and it's something that we're starting to think more and more about, because it means that everybody is happier to do it. And as long as the ward can absorb the absence of a couple of staff for a couple of hours, what a winner. And the other bit we're doing is getting people home and holding the beds just until that evening or whatever, and saying, we'll see where you're at, but we won't discharge you.
Evesham used to do that as well with the stroke patients, isn't it?
Dawn, can I ask you something really quickly? Do you also have discharge coordinators or discharge facilitators? Okay, that's fine.
Yeah, we do. It's one of the nice quality standards that we need to consider. And what we've been doing, excuse me, coughing, we've been using our registered staff to do that function, but obviously it's a different nurse every day. What really matters is, we've called it the glue, that person who's there Monday to Friday, who knows what conversation was had yesterday with whom and which one they need to follow up tomorrow. And we're very clear it's a band 4. It is not a registered role, because I stand very true to registrants hold the discharge rights. That's not being devolved. But knowing what's been happening, my God, that's making a difference. So we've got a band 6 onward care lead who helps us to lead them forward. She's a little bit like their professional voice. And then those band 4 discharge coordinators are now starting to be on every single ward. And we funded them at cost in some places. We funded them out of some of our staff nurse lines and mix and match. And my maths isn't very good, so whoops, I might be slightly overspent. But, do you know what? If it means that we can get people where they need to go, that's pretty powerful stuff. And again, it's a new role. It's embracing that, but it's making a difference.
Thank you. Because those are the two things we've trialed actually on winter pressures. One is the therapy weekend cover, which again, we did exactly the same. We offered it to bank, and many of our staff, and especially the therapists, they don't get the enhanced pay, but they've got the opportunity to have the enhanced pay over the weekends, and then they get the day off. They can do a lot of shopping, banking, all of that. And then we also piloted, the discharge coordinators. And after a big battle, we've now finally got full funding approved for the discharge coordinators, and they sit very closely with the therapy and the nursing team, and also they also link in with our single point of access for the onward care referrals, because they are a completely different team. For us, we are quite spread out. linked in on a daily basis with them, with their trackers and etc. So and I think using your sort of evidence will help me as well to get the therapy band 7 the 7-day working, because it's working in your area. We've tried it and unfortunately suspended it because of funding again being an issue, but I'll probably be pulling your name for a lot of things, saying it don't seem that this works, so maybe we should be trying this if you don't mind.
No, not at all. Please do.
Thank you.
Well, we had an extraordinary time during COVID, didn't we, where therapy physio clinics were closed because of COVID. And so therapists transferred over to the ward, redeployed in the wards, and all of a sudden, actually, enhanced therapy could be offered in some community hospitals. And it was an extraordinary experiment that, because of the shortage of therapists, we couldn't have done before. But it really showed the benefit, and I think it's given us all a taste of what could be achieved if we are able to offer therapy every day, as opposed to most weekdays. So that was an interesting experiment. Anybody who hasn't yet asked a question, who fancies? There's so much in Dawn's presentation, it's hard to know where to start. But any other questions coming from anybody? No, I think you have stunned us into silence. I'm interested in your work with local people and communities, because that needs a big investment of time. And we know that, if there's a suggestion of loss of services or threats to community hospitals, local communities are out in force because they really value their community hospital. But to keep communities continually involved in the community hospital is an interesting one. So I just wonder how you resource that and how you make that happen.
Our League of Friends are pretty awesome, and actually our chair has phenomenal relationships with all of our League of Friends, and I have to say that's hugely helpful to us. And that's not to say it doesn't come with thorns. Sometimes sitting in HOSC isn't comfortable, but the reality is we have got our services where they need to be. For example, through COVID, we put our stroke bed up to 20 instead of 14, which meant that we lost the 6 general pathway 2 beds. And rightly, our public said, well, hang on a minute, we want those beds back. So it was about working with those expectations and understanding them in the system context. And I think we're quite mature as an organisation in how we work with our communities. We're building a new Forest Hospital. It's taken 20 years to put the bricks to the ground for that. And only yesterday, our chief exec was sat with one of the local health forums to talk about what it means for their urgent care services, for example. So we're really open and transparent, and our dialogue is very strong. Our NEDs are very helpful. They have some really solid relationships into our communities. But genuinely, they are really supportive to us. We get Christmas presents for all the patients from the League of Friends. They fund a huge amount of equipment for us, and they support a lot of that local charity raising. And it goes back to, we do need modern healthcare services, and we do still practice a bed is a bed. It's not just that Tewkesbury Hospital is just for Tewkesbury patients, but equally we will always try and repatriate people closer to home because that helps everyone. But the League of Friends work with us because we are as open and honest as we can be. But it is you have to nourish, and you have to keep working with. You can't just do a nice bit of work with it and then walk away. You have to be willing to hear that voice of the public. It's not always as articulate or in the language that you and I might understand as healthcare colleagues, but underneath it all is the essence of something that's troubling someone, and we've got a real duty to listen to that. So we've got things like fairs going on. One of our hospitals is 100 years old in a few weeks' time. We've got bands on the lawn and tea and coffee and ice cream, and over 100 odd people expected to attend. And that's been done through partnership between the matron and the League of Friends who've organised it, and the friends of that site. So we're not naive to the political risk, and I think that's a fair comment. It works better if we work together, but it can be a little bit tussly. But increasingly, we've got clinical programme groups which are working with that public voice. So they're seeing more of how we operate and what we do, and understanding our journey to decisions and being part of those decisions. So it actually, I think, is getting easier as the ICS matures as well. And Gloucestershire is quite lucky. We are coterminous and have been for many years. So it does make it a little bit easier for us. But I would be a fool if I sat here and said that we just continue regardless, because the public people power is incredibly strong.
Yes, people value their community hospital, definitely.
But equally, they value what we're doing. So one of the conversations about the Forest Hospital is actually, yes, we're moving from 2 to 1, but we're bringing you modern dental facilities, an endoscopy unit, and an all singing, all dancing outpatient unit, and infection control compliant single rooms out here, and a bigger minor injury and illness site. So we've had constant dialogue about the benefits of the changes, and we did something called a citizens jury, which was written up nationally, which decided where that hospital was going to be based. Now, there aren't many trusts that would be brave enough to go down that route, and Gloucestershire, as we were, Gloucestershire Care Services, we've been brave all the way through, because we knew that this was going to need some brave decisions and leadership, and things like that are an example of what our organisation has stood for, and I think that stands us in good stead. There is a real heart to our organisation, and I think that helps me to lead my teams, to be honest.
Well, it's absolutely stunning, and I suppose there are so many strong messages from your presentation, but I think the way that the community hospital is embedded in the health system, and there's lots of messages about integration, and you're describing how staff work together, how you work with the communities, how you work across the system. So it's utterly inspirational, and I suspect all of us will sit and study your presentation at length, because there was so much covered in a short space of time, and so much that's relevant to all of us. We're just in the last 5 minutes, so I'm just going to go around and make sure nobody's got anything else to say. Peter, is there anything? Peter Levin from Cornwall, a researcher. Anything you want to say or add?
Well, first of all, thank you. It's you packed a lot in, and it's been inspiring, and I would be interested to know if you have written anything, because in effect what you presented was a how to do it manual.
I don't know if it's a how to do it manual. I can't sit here and I'm the face of community hospitals for this organisation, but I go back to, I've got phenomenal staff. So we are, for example, writing up the Enhanced Pathway 2 work for the HSJ Awards. We've got nurses who've received the Cavall Nursing Awards as a result of the work that they've done with our improvement, for example. We've got some local things. We have talked to we've got an R&D team. We have talked to them about how do we get this moved forwards? How do we publish some of this stuff? In all honesty, we're a little bit stuck on bandwidth and space and time for busy teams, but there is a lot in here. And I've been around in community hospitals for about 18 months now. And, you know, I came from district nursing, and I had a view of what community hospitals were. And I'm really delighted that many of those stereotypical views, let's be fair, have been put to bed, and taking my teams forward has been really easy, because they were just ripe for picking. But whether we can do something with it in the future, we would never say never.
I think we'll be having some more conversations with you, Dawn, about research, because I think, you know, we do want to see the evidence base so that we can share the practice that's going on. So, but I know the time and effort that that takes, but we don't want to lose any of this in terms of learning for other organisations. I'm just going to call out people randomly, just if you don't mind. Claire Lines, is there anything you want to say? Oh, hi.
Oh, well, hi, hello. Just say thank you so much. I mean, it was brilliant presentation. I was cack-handed during the presentation, trying to make contact to see whether there's somebody I could follow up with in Gloucester afterwards. So I'll try and do that. But, you know, we're highly rural area, 10 community hospitals, facing many of the same challenges, thinking about doing the same things. We don't have a district general hospital in our area for 100 miles, and everyone goes beyond our borders. So really interested in some of the ideas that were put forward. So thank you.
Well,
you're welcome.
thank you
Just get
much.
in touch.
Claire, are you from Powys?
Yes, yeah, and in fact I'm with Marion and you're the director of nursing for your ICB tomorrow on our cross-border network meetings.
There you go, the connections continue. Sarah, anything you want to say? You don't have to speak. Sorry, I feel awful. I'm picking on people. But Sarah, is anything you want to say before we finish? No, Sarah may not be there. Lisa? Oh, hello, Lisa.
Hello. So it's easy for me because I work with Dawn anyway, because I'm her business manager for ambulatory care. So outpatients, theatre and endoscopy sit with me across all the co-hosts. So yeah, I'm part of the journey.
Oh, brilliant. Oh, it's so nice to see you and to hear about all that you're achieving. That's fantastic.
Yeah, we've got a fab team.
But I think there is something within this. Lisa's a business manager. Having commercial savviness in my team isn't something you'd usually find in a recipe for a community hospital leadership team. So, you know, project management, business management, commercial work, the work that Lisa does, you know, we've got strike action coming up. Lisa's pinging emails at me. She knows exactly what's happening within our system that's going to affect us. So I can't begin to explain how lucky I am. I haven't got just the traditional tools in my leadership armory. I have got phenomenal management capacity with people with the experience that Lisa brings. So I think one of my advocacies for this is actually think differently about the roles you need in your leadership teams, because you do need some slightly outside of the normal sort of people with skill sets that you kind of think, well, really? And then suddenly you've got something very different. And I think, Lisa, we benefit from that, don't we?
We certainly do. We certainly do. I mean, you know, care closer to home. We've got so much going on for our patients in outpatients, theatre and endo. It's brilliant. Not least the income generation that it brings to us as a trust. You know, in the 5 years I've been in post, we've gone from 3 million income to 5 million income. So, you know, it's not a small figure, really.
Mm-hmm. And certainly we've had the impression of you building a strong team, Dawn, in terms of all the resources and skills that you need. Tom Rose, did you want to say anything before we finish?
A couple of points. Jan mentioned research, and as a researcher myself, I think that's a really good idea. But one thing, I mean, the presentation was great, but it does seem to sort of conflict a little bit with research, because there's so much change going on. I don't know how stable your organisation is, but it must be stable for you to achieve what you're doing. But there does seem to be an awful lot of change.
Yeah, there is. And we've been really mindful to try and spread that out, because I've got the 7 different sites. So I can, but it's then as that learning surfaces and grows, how do you then cross-pollinate that? We don't wait for the evidence to come out in a published space. Actually, we know the evidence because we're seeing it through our governance and our tracking and all our data. So I've got that beautiful sweet spot where we can go, actually, that did do something, that is changing the dials. So now we can do that internally. And I think if we were to ever go to the market with this as a publication, actually it would be multiple separates, because the concepts of what we're doing, yes, it's building to a big master thing, but fundamentally they're dolly steps to change, and they are mounting up. And we always said last year into the early part of this year was going to be a significant transformation year for our community hospitals. It did need to modernize, but for example, this year everything's about embedding. So we've got a bit of a gas on, gas off process going on, because you can't just keep pushing at teams all the time. It won't work that way. But they take the good stuff and they share it themselves. It's actually really easy once you set marbles rolling for them to keep knocking on to the next one.
Mm-hmm. Okay, thank you. Eleanor, I was just going to ask if you could just say what happens next in terms of links and presentations and stuff.
Yes, indeed. Yes, so following this evening's event, about a week later, actually, we'll send out an email to everybody who's attended with a video and a certificate of attendance as well. And then for others who've registered as well, they'll also have access to the link. Yeah.
Brilliant. And you're happy for your presentation to be shared, Dawn?
Yeah, that's fine. I'll send it over to you, because I'm aware that I've tweaked it slightly since you guys saw it. So I'll send that over to you now. Shall I send it to Eleanor? Is that the place to send it? There you go.
Thank you, Dawn.
Okay, well, it's 8:30 and we've had a bumper packed an hour and a half. It's been brilliant. Thank you so much to Dawn. Thank you very much for giving us the time and sharing all the fantastic things that are going on in Gloucestershire. And I think we've made some very nice connections this evening. So I think we'll all be in touch with each other after this. But anyway, I think we'll enjoy the rest of your evening, and thank you to everybody who's attended. Thanks very much.
Thanks, everybody.
Bye-bye.
Thank you, everyone.
Thank you.
Thank you.
Bye-bye.
Bye.
Bye.
Bye-bye.
That was good. Oh, sorry.